Well, good morning, everyone, and welcome to Pediatric Grand Rounds today. My name is Minnie Dasgupta, and I'm one of the Pediatric Chief Residents here at Stanford. Before we get started with our talk today, which we're really excited for, I just wanted to remind everyone of the upcoming Grand Round sessions that we have. So next week, we'll be having a talk on perinatal care in the context of COVID-19. And the following week, we have our Pfeiffer lecture speaker, Dr. David Acosta, who will be giving Grand Rounds. Just a reminder, on the left side of our screen, we have the text code confirmation information if anybody needs that for attendance. So today, my co-chief residents who are here with Dr. Danielle Turkey and Dr. Jake Weatherly, and I all have the pleasure of facilitating this really special and annual Grand Rounds. And that's because it's in honor of a past Stanford Pediatrics resident. So today we welcome our special guest, Dr. Lucy Kalanithi, to our Rudene Di Carlo Memorial Lectureship in Pediatrics. So Dr. Kalanithi was nominated and chosen to be our guest speaker by our very own pediatric residents. She is a graduate of the UCSF Internal Medicine program, and now she is a clinical associate professor right here at Stanford. She is the widow of Dr. Paul Kalanithi, author of the #1 New York Times-bestselling memoir, When Breath Becomes Air, to which she wrote the epilogue. But before we dive a little bit more into Dr. Kalanithi's background, her perspectives, and the other goals of our discussion here today, I want to introduce another very special guest, Dr. Marianne Carmack, who's going to take a moment to share with us the story and the legacy of Dr. Rudene Di Carlo, the former pediatric resident in whose honor this lectureship was originally named. So Dr. Carmack completed her pediatrics residency and her fellowship in infectious disease here at Stanford. And she recently retired from a career at Palo Alto Medical Foundation, during which time she was also a Stanford adjunct faculty here in the Department of Pediatrics. And she has chaired the Rudene Di Carlo Lectureship Committee since its inception in 1995. So thank you so much for being here with us today, Marianne.
Good morning, everyone. It is truly my honor to tell you about Rudene Di Carlo, for whom this lectureship is named. It was my good fortune to overlap with Rudene in the pediatric training program, 30 years ago. And I was blessed to be one of her many friends, and I do mean many. Her mother liked to say that Rudene had more friends than zebras have stripes. So the wild jacket I'm wearing is a shout out to her and other family members and friends who are watching this morning. In talking about Rudene today, I feel a mixture of melancholy for the loss of a friend, but also excitement that we are remembering her in this constructive way. My goal in the next few minutes is to paint a portrait of Rudene to help you understand why, after all this time, we still remember and honor her with this lectureship dedicated to exploring the topic of compassion in patient care. Now, as you know, our speaker today is Dr. Lucy Kalanithi, whose late husband's book many of you have read. There are remarkable parallels between Paul's story and Rudene's. Both were promising, talented residents, passionate about patient care. Both were destined to be stellar specialists in their fields. Both would have improved the lives of hundreds, if not thousands, of patients had not a cancer that was rare for a young adult struck them down. Both were determined to complete their residencies and did so heroically. And both left their indelible marks on colleagues who will never forget their care and compassion for others, despite their own terminal illnesses. Well, here is Rudene's story. The year was 1991, and Rudene was soon to graduate from Tulane Medical School. She was excited about beginning her residency in pediatrics at Stanford, her first choice. During the last few weeks of medical school, Rudene decided to donate blood. 4 days after graduation, a letter informed her that screening tests on her blood were abnormal. She and a friend went to the blood bank where they looked at the blood smear and saw for themselves the abnormal white blood cells. The diagnosis would prove to be chronic myelogenous leukemia, a rare cancer in a young adult. Well, it did not occur to Rudene not to begin her residency. In fact, initially she told no one in the program, not wanting to be treated differently. When she did begin to share her confidence, we could hardly believe it. She was so vivacious, positive, and forward-looking, determined to be a pediatrician and eventually a pediatric oncologist. Rudene inspired us. She always put the patient first. She always put her friends first. She was detail-driven, not to impress others with her knowledge, but because it mattered to the care of the patient. We felt awe for her energy, intelligence, cheerfulness, and especially her compassion. As time went on, her disease inexorably caught up with her, and it would be 10 years in the future before a treatment would be developed for her form of leukemia. So she courageously underwent 2 bone marrow transplants, in between returning to her residency rotations. When she was hospitalized, her many friends would crowd into her room to laugh and gossip. She would joke that the effects of chemotherapy were like an elephant seal molting, shedding its skin for the new season. But sometimes the conversation became serious as we would ask what lessons she could share from the perspective of being a patient. I'll never forget her words. "It's the simple things, really," she said. "Sit down when you talk with patients. Wear a name tag. Identify yourself. Involve the patient in decision-making. Keep promises the patient will remember, and never underestimate the importance of touching the patient." Her points were deceptively simple and deceptively hard. In the epilogue to Paul's beautiful book, Lucy wrote, "What happened to Paul was tragic, but he was not a tragedy." Well, so too with Rudene. The experience of knowing Rudene through her illness and death was poignant and life-changing for her physician friends as we watched her graciously navigate a system that was imperfect in returning to her the compassion she would have delivered to others. For example, she told us about the time the medical team was rounding on her ward. She heard them outside her door, talking and laughing for several minutes, only to spend less than a hurried minute in their visit with her. She shared this story with us not as self-pity, but to be instructional and observational. It was a teaching point, and we could certainly catch a glimpse of ourselves in similar thoughtless indiscretions. It is the juxtaposition of the perfect in Rudene, the imperfect in the system, the imperfect in ourselves, and the desire to make it perfect that has kept this lecture alive all these years. And I can think of no better way to help us learn from Rudene's example than a fireside chat with Lucy Kalanithi and the chief residents. Thank you.
Thank you so much, Marianne, for sharing that touching story with us. And for those of us who didn't have the pleasure of meeting Rudene, for helping us to really better understand her story and kind of what she stands for to all of us today. We'd also like to extend a very special welcome to Rudene's mother, Rudene's stepmother, and several family friends who join us every year for this memorial lectureship and are with us virtually this year as well. So now I'd like to turn back to Dr. Kalanithi, who, as I mentioned before, is a clinical associate professor in internal medicine here at Stanford and wrote the epilogue to her late husband's book, When Breath Becomes Air, as Marianne mentioned. She is an advocate for culture change around healthcare and with a particular focus on end-of-life care, caregiving, and clinician wellness as well. So today, from perspectives both as a physician and as a family caregiver, Dr. Kalanithi is going to discuss the role that trainees and all physicians can play in the delivery of compassionate care, and we'll be doing that in the form of a fireside chat. As a quick aside to our audience members, we are planning to save about 10 to 15 minutes at the end of our session for audience questions. So you can use the Q&A feature at the bottom of your Zoom screen to submit questions throughout the talk. And Jake will be helping us to organize and share these questions at the end. So thank you so much, Lucy, for being here for this fireside chat today. We're so happy to have you. One benefit of having this be virtual is we get to have an actual little fireplace with us, so we're happy about that. So thanks again for being here.
It's such a treat. Thank you so much for having me. I'm so honored for this nomination to join you today. And then I also just wanted to say a special hello to Rudene's family. I am so sorry for your loss. I relate to you so much in the drive to continue to honor and share somebody over time and to continue your own relationship with them. And so I wish that we were able to be together in person today to connect over that, but I just wanted to say, hopefully you can feel our warmth today as we're thinking about you. And so thanks for having me. And to the residents who brought me, congratulations, especially to the people who are graduating this year, including you guys. So thanks again.
Thank you. And, Lucy, we just heard, like you referred to, this amazing story about a pediatric resident who struggled with her own significant illness, who worked really hard to kind of balance her training as a physician, which she was really dedicated to, but also managing her illness. And Marianne alluded to several parallels between Rudene's story and Paul's. So can you share with us sort of some of your initial reflections on her story based on your own experiences?
Yes, of course. Obviously, there are so many parallels. It's really interesting to hear. It's been interesting to learn about Rudene. A couple come to mind. The first one, I think, is just the very simple but profound fact of a physician becoming a patient. And I don't mean in the way in which that I don't think that a physician has to become a patient to develop a deep well of empathy and deep skills in connecting to patients. But I do think it's very powerful to have a literal embodiment of somebody who's both. It's almost like Alice in Wonderland going through the looking glass. And I think, Susan Sontag talked about, we all inhabit variably the kingdom of the sick and the kingdom of the well. And you hope that you don't have to take your passport into the other kingdom. And but I think, one person being physician and patient at once, and then sharing that experience it sort of shatters the there's us and there's them mentality. I think it's the fact that both Rudene and Paul decided to become teachers in a different way and to talk about the blurring of those barriers in between people is really powerful. And so that is a very clear analogy to me. And then I also think, hearing Rudene's story of training as a resident and then doing the bone marrow transplants, I actually am so impressed by the physical discomfort that comes with that. So having witnessed that kind of thing in a loved one, I just think immediately about the arduousness of undertaking what she took on, like Paul did too. And I think when that moment of Rudene looking at the peripheral smear herself felt like an analogy to when Paul in his writing and describes what it was like to look at his own CT scan, to receive a diagnosis that way in an unmediated way, to see the fact of your own body and to see the fact of your illness very starkly and know what it means. And I think when you get a diagnosis like that, at least in my observation, and Paul, there's the challenge of facing your own mortality and thinking of yourself as a fragile, embodied, physical, mortal creature. But I think mortality aside, the challenge of having your identity upended, I think when you get a diagnosis like that, you realize how much of your current identity is tied up in your future self, like who you imagine yourself to be, whether you're having a child and thinking about that child growing up, or whether you're training as a medical student and picturing years as a specialist and as a leader in the community, and then to suddenly have that future self threatened in a serious way. You were one person 5 minutes ago, and now you are a totally different person after getting that news or seeing that smear or scan. And so I think a lot about the work that it took Paul and the work that it must have taken Rudene to figure out how to move forward in this sort of new existence. And then one other thing, I like that story about Rudene being a patient and then hearing the team rounding outside and this sort of admonition about taking time to joke around and then not taking a lot of time with your patients. It's so relatable. And I think we've all been that physician, and Paul was, and Paul talks about that. I'm sure Rudene admitted to her own, faults. But I love that she, like Paul, was sort of pressing for perfection in a certain way, holding herself to a very high standard, and Paul wrote in his writing, we can't ever reach perfection, but we can believe in an asymptote to which we are constantly striving. And, you know, whether or not we can cure our patient, we always have compassion to offer. And I love that she was talking about this asymptote of compassion. And Rana Oddish is a physician writer who wrote about being a critically ill patient herself, and hearing the team outside using various language that she had used a lot, like this patient is circling the drain, or this patient's been trying to die on us all night. She talks about these things that roll off the tongue of a physician, but when you're the patient sound so jarring. And then in the same essay, it's a New England Journal essay about her experience, and she writes the sentence, something like, everything matters always, every patient, every time. And it's such a high, intimidating standard, and yet it's so important to be striving for that all the time. And so anyway, those are some of the things that come to mind. I feel so connected to that story. And anyway.
And thank you for sharing kind of so many of the parallels. I think, you know, it's so clear to those of us who are hearing the stories of Paul and of Lucy that exactly as you described, this level of perfection that they're working to achieve, and in so many ways, their stories have impacted so many people. Mm-hmm. And so, you know, if each of those people, or even some of those people, take small steps to kind of be better in their care of delivery, they really are both making such a big impact in helping physicians get there. And I think the fact that, you know, 30 years later, we're still talking about Rudene's story and learning from her story and learning these kind of simple tenets that we're all looking at over and over again shows the impact that they've been able to have on so many people.
So particularly in the world of pediatrics, we find ourselves caring for the entire patient and often treating both the parents and the child as our patients. Can you tell us about your experiences as Paul's caregiver and how you as a family member felt empathy was expressed by your medical team?
Yeah, sure. You know, one of the ways in which I think empathy was expressed toward me specifically, maybe I'll start with that, is feeling recognized as a very important member of the team that was taking care of Paul. I think you know, it was such an effort all the time to be thinking about how to manage Paul's symptoms and then also how to help him reach the goals that he wanted to accomplish. You know, when Paul was writing this memoir during his illness, you know, it was like timing naps with medications, with how to sit comfortably despite having bone metastases, to, you know, his physician let him take a stimulant off label to help with focus during writing, you know, when the fatigue of cancer was really punishing and he was on medications with side effects. And I think it was all consuming as a family to be involved in that, of course. And then of course there's multiple layers to the stresses that come to caregivers. And we didn't have many of them because we had so much medical knowledge, and we had health insurance, and we had community around us, and we had the ability to be a visitor in the hospital, which patients now don't have. And so anyway, despite not having many of those layers of suffering, it was immensely hard. And I think one moment I remember is Paul's oncologist. Paul had been prescribed a new medication of some type. And she said something like, "How's the new medication working out for you guys?" And the "you guys" part, just recognizing that it was working out for both of us if it was working, was so beautiful. And then I also think, you know, to Rudene's point about it being the simple things that are so important, there was a moment where this was the nurse practitioner in the oncology practice at Stanford, where, you know, multiple months into Paul's diagnosis, the cancer progressed. And it's sort of a new devastation when your cancer progresses again. It's like getting a diagnosis again. And I remember the nurse practitioner saying something very personal and sensitive. She said something like, her name's Allison, and she said something like, you know, I really wanted you to be the guy who's on Tarsiva for 7 years, and you're not that guy, and I'm so sorry and sad about it. And she just said something like that, that was very personal and not polished exactly. And I just really appreciated that moment, because sometimes we feel like we're supposed to say some perfect polished thing that's very professional. And I don't know, I just think those personal words, they're so memorable. You know, that was now a little over 5 years ago. And then I think another way in which Paul's caregivers were immensely helpful and a sort of a form of empathy was what I had mentioned before, which was tailoring the care that he was getting to his goals and real life as a person. And so, you know, his palliative care team and the oncology team were very interested in hearing what was going on with him. And you know, at first it was choosing chemotherapy that would not cause peripheral neuropathy, so that he had the option of remaining a surgeon, which initially sounded so impossible to us. And the oncologist was the one who held open that possibility for Paul, even when he didn't believe he could do it. And then, you know, we decided to have a baby during that time, and they were very invested in that, of course. And, you know, I just think the conversations around trade-offs of treatments were always taken in the context of what Paul was hoping for. And yeah, I think about that a lot. Yeah.
I mean, as you already have mentioned, we can only imagine how much this has shaped how you treat your own patients and their families. So we would love to hear you comment a little bit on what your current practice looks like as well.
Yeah, sure. So I'll just say one thing actually, and this ties into my own thinking about my practice, and then also a reflection of what I just said. There's a really interesting study. I don't know if people have read it. It was actually done at Stanford. I think the PI is Alia Crum, C-R-U-M. I don't know if I'm saying her name correctly, but she did a talk at TEDMed a few years ago called something like The Power of Placebo, if anybody's interested in watching it. And she actually talked about these two axes of like two really important things that are really important that a physician provides to a patient, and they are competence and warmth. And just to mention it, her lab did a study where they brought in patients and they injected some kind of histamine or something that caused a little itchy wheal on the skin, like a little itchy circle. And then they had a sort of physician actor come in, and they varied the physician's warmth and they varied the physician's competence in whatever way that was operationalized. And they found that a warm, competent appearing clinician who said, you know, I'm going to apply a cream and it's going to help the rash go down. The cream was actually inert and not anything. It wasn't hydrocortisone. It wasn't anything that would make the rash go down. But the physician seeing it and appearing warm and competent helped that rash subside. And if they varied warmth and competence, the rash did or didn't subside on the patient. And I'm sure that only works on like certain types of illnesses, you know, like things that are neuroendocrine axis or just something. But there's been a lot of data that, you know, links things like medication adherence to the relationship with the clinician. And so I think often about how, you know, these are often thought of as soft skills or like this extra bonus on the side. And I think having warmth be a central part of your practice actually is directly influences quality in the ways that we measure it. So anyway, for what that's worth, I wanted to mention that. And then my own practice as a physician, the thing that's been most important to me is just that my connection to caregivers has certainly been heightened whenever I go into a room and I see the family member sitting there, whether it's an adult child of the patient, often in my practice because I'm an internist, or a spouse. I notice them so much and acknowledge them, ask them how they're doing. And then I think about the policies that are affecting those people and the lack of policy support that's affecting those people. And then I work in, so my practice right now is in urgent care at Stanford. So I'm not an inpatient physician. Sometimes I make serious diagnoses like new cancer, but I'm not routinely dealing with critically ill patients or patients at the end of life. But even in the tiniest interactions in my clinic, I think compassion is very central. And part of it is, in urgent care, I have one encounter with the patient, but they're there and they're stressed and they're there for something specific that they are worried about that day. And so I need to figure out how to form an alliance with them very quickly so that we can make decisions together. And then I also think, even in a simple interaction, like one of the classic dilemmas or encounters in urgent care medicine is a patient who comes in with a cough and they're sure that they need an antibiotic. And, physicians are often, you hardly ever need an antibiotic for an acute cough, except certain situations. And, but everybody thinks that they need a Z-Pak. They're there for a Z-Pak. And I think instead of launching into a discussion of the risks and benefits of antibiotics and the Z-Pak and population level resistance and blah, blah, I will often just say, what's really important to you about the antibiotic? Like, what do you think will happen if you take it? And they'll say something like, my sister had serious pneumonia and nobody figured it out because they didn't listen to her. Or I have to give a presentation at work tomorrow and I must be on point for that presentation. And then I can adapt my recommendation to that and say, actually, let me recommend a different treatment, this, and this, and this, that I think will get us there. Like, how does that sound? I think that's actually going to be the best thing for this. And it goes a very long way. And so, I don't know, I think about it in terms like that. And then I think about, can I tell like one story about a difficult encounter that Paul had? And this sort of overlaps with a discussion of burnout, which I know we want to talk. I now realize it overlaps with a discussion of burnout. So this is a story I wanted to tell about sort of a personal reckoning about patient autonomy in a way. And this has affected my own practice and humility as well. Paul writes about an encounter in the book where he had a difficult interaction with a clinician, and he was admitted to the hospital for complications of chemo. And during that admission, the oral targeted chemotherapy pill that he'd been taking for months and months was left off the inpatient medication list. So he was not prescribed that medication as an inpatient. And he told, it was actually a clinical fellow. He wrote resident in the book. I don't know if he didn't remember. I don't know where it's at. But he told the fellow and said, I need this medication. I get really severe pain if I skip doses. And the fellow said, your liver function tests are elevated and I don't want you to be on that medication. He said, well, I think we need to call my oncologist. And really, I've had, 10 out of 10 pain when I've missed that medication. And the fellow actually said something so intense. He said, if you weren't you, I'd make you prove that you had all that pain, which was so striking and such a wild statement on power in the hospital. And ultimately, the medication was added to Paul's inpatient medication list, but I was there sleeping on a cot in Paul's room, and I actually had that medication in my purse in like a little pill bottle that I used to carry around that also had pain medications and anti-inflammatories and all the things that you might need. We had it all stuffed into one bottle, and we knew what all the pills looked like by just looking at them. And Paul took the medication out of my purse and took it at 5 a.m. or whatever as a hospitalized patient. And it seemed like the very obvious thing to do. And yet, if I had been the inpatient resident or attending or whatever, I think, and this is like the situation where the patient takes the home med from his wife's purse. And, it's like, that is such a, it's very unorthodox, and it obviously is in a way a patient safety issue if it hasn't been prescribed, and it's sort of a personal affront to the physician, et cetera. But it felt so obvious at the, from the other side that you know, it's when you're the patient, it's your body in the context of your life, and you are framing the risks and benefits to yourself and making decisions as a autonomous person. And I think that has made me think so much about autonomy and my own sense of, you know, I am not totally in control of what my patients do, nor should I be. But I think you can lose sight of that, surprisingly, but not surprisingly. I think that brought it into stark contrast for me. So just one other thing to mention. Oh, and then what I was going to say about burnout is just that it's taken me like 5 years to forgive this person who, you know, made this comment to Paul. But then it's sort of occurred to me as I am advocating for system reforms that will reduce clinician burnout, that, you know, this clinician himself may have been feeling so depersonalized and tired and exhausted with very little emotional reserve. I mean, like that's definitionally what burnout is. And so it took me a while to see him as a person. I don't actually think we should expect our patients to necessarily consider our needs in their encounters. I don't. But I do think about that guy now. And I think about how he's like, if he recognizes himself in Paul's book, you know, what that is like. He's anonymous. But anyway, some thoughts.
Yeah, and it's interesting to kind of echo Rudine's sentiment of how it's the simple things. You know, there's this one comment that you are thinking about 5 years later, and I think that just kind of echoes that, like, patients remember what physicians say. You
Totally.
know,
yes, right. That's what you said. Yes.
Mm-hmm. You know, you alluded to this a little bit earlier when you were talking about kind of families having resources and how you guys were lucky to have a community locally where Paul was receiving his care. And one thing we kind of wanted to touch on, you know, we're in different times right now. And from a physician perspective, some of the simple suggestions that Rudene made required a physical presence in the room with the patient. So, you know, she mentioned sitting down, touching the patient when able, and things like that. And in this current climate, you know, maybe not for the most critically ill patients, but for many patients, inpatient and outpatient, physicians are providing care remotely or over the phone or from outside the room. And so how can we kind of modify compassion in this setting where some of those simple aspects that we often rely on are taken from us?
Totally. And you're talking about during this pandemic, right? Like just all the ways that this is such a lonely, it is so lonely. It's wild. It's like, it is so lonely across every aspect of everything, right? Obviously for shelter in place and for people feeling neglected and disenfranchised. And then all the people who are hospitalized, and we as clinicians feel it too, right? It's not fun to be wearing PPE. And you realize when you go into a patient's room that your entire outfit is saying, I don't want to be here, right? It's like, that's what your outfit's saying, right? Even if you are not feeling that way, and maybe you are, maybe you're feeling scared. To me, I think it has felt helpful to acknowledge it, to like explicitly say, thank you for doing this visit by video. It's unusual for us, and like, please let me know, blah, 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 how it's going for you. Like acknowledging that. Same thing with patients who are alone in the hospital. I've seen so many creative responses to exactly what you're asking. So one that is actually centered at Stanford now is Mary Beth Heffernan's project called PPE Portrait Project. And I think this is beautiful. You guys would love it. It's Mary Beth Heffernan is an artist who made this idea come to fruition during the Ebola crisis in Liberia. And basically, she has a very simple project where she takes a smiling picture of the clinician and turns it into either a laminated card or a disposable sticker, like printed on a label, that sticks right on the outside of their PPE gown. And it's gorgeous. And it's a picture of the person smiling at you. And so I'm in COVID clinic at Stanford, and we're doing that. The medical assistants are doing it. We're doing it. And it allows you, obviously for for the patient to see your face. And it also shows that you took the effort to make the sticker, right? There's literally no reason to take all the effort to make the sticker apart from you want to smile at the patient. And so PPE Portrait Project is what it's called. And Katie Brown Johnson is the investigator at Stanford who's rolling it out and now studying it. And she's studying the effect on clinician experience as well. And then, of course, we've seen projects to bring iPads into patients' rooms in the hospital so that they can communicate with their family members while they're isolated. I can't imagine the loneliness and fear that is happening for individual patients in their rooms. And then you guys might also be very interested. Do you know Vital Talk and Tony Back's leadership at UW Seattle? So he's a, I think, oncologist and palliative care leader who runs an organization called Vital Talk, which was initially designed to train medical oncology fellows in end-of-life care communication or communication about serious illness. And his team, Vital Talk, made a COVID-ready communication guide for clinicians. And so they have always worked on communicating difficult news to patients and eliciting patients' values, et cetera. But then they made a communication guide specifically for COVID, and it includes supporting patients through a hospitalization that they're facing alone, making difficult decisions with surrogate decision makers, but remotely. And then the most beautiful thing that's going to bring tears to my eyes is they even have a guide for assisting with a goodbye between family members for a patient who's dying in the hospital but isolated from family members over phone or video. And it's not just about technically how to do that, but it actually gets into how to facilitate a goodbye. And they even coach the family and say, you know, there's actually been studies and writing about what it is family members, the themes that family members sometimes say to each other at the end. And if any of these resonates with you, we wanted to share them. And there's actually 5 things, and they are: please forgive me, I forgive you, thank you, I love you, goodbye. And they coach people through how to do that. And I just think, and then they affirm for the family member, wow, if I were, you know, that would be so meaningful for me to hear. Do you want to practice that? Do you want to, like, just whatever they need. And then they stay connected to the family member after that process too. It is so amazing. And so it's just been wild to see all the creative ways to do this, because it is just so lonely. And I also think it's been very interesting to see public health and population health as compassion writ large. You know, like the idea of physical distancing being a loving act is so like interesting and counterintuitive and contrasty. And then I think policy and advocacy being compassion writ large as well, and thinking about, you know, the very disproportionate impact of COVID on people like essential workers or Black and Brown communities and nursing homes is very distressing, and not something that's new, but I think something that is becoming visible very starkly during COVID. And so I think thinking about how to operationalize compassion in terms of public health measures and advocacy is a very important part of this as well. So yeah, but it's really sad.
It's interesting, you know, you mentioned this, you know, really beautiful system, it sounds like, about communication around goodbyes. And I think because we're in this bizarre environment, it is prompting people to be creative. And I think what we're learning is there's so many things that we could be doing even in normal settings.
Yes, yes,
so I
right?
think that's a perfect example. Like,
yeah,
you know, someone who's never experienced that, and afterwards maybe I wish I had said I forgive you, or, you know, goodbye, and all these things. And those are sort of counseling that might apply to anyone, anywhere. And so I think, you know, there are good things coming from these bizarre times too.
I think that's right.
And then Lucy, you sort of mentioned the topic of sort of burnout already. We've talked about the current climate, which is providing distress and difficulty sort of amongst all people. And we know that you've done a lot of work around physician well-being, and this is a topic that we also feel quite passionate about as chief residents and as recent graduates. What kind of experiences do you draw upon to bring happiness to yourself even throughout hardships? And how can residents or other physicians do the same?
Yeah. So I guess there's like a couple of layers to that, right? And it's like when I think about burnout, of course, there's sort of two big buckets and sources of burnout, right? One is personal resilience and personal resilience factors, which you're asking about. And the other one is system factors, which are so important. And initially were not recognized, I think, in the beginning of thinking about burnout. There was too much of a focus on personal resilience rather than system responsibility. For me, I think, you know, these are like the things we tell our patients and that I'm talking to my patients about that. So I had an episode of depression in residency actually. And I was a third-year resident and ended up taking 2 weeks off and talking to my program director about it and the chiefs, and never thought that I would be mentioning it publicly. Like I would have been very shocked to learn in 2010 that in 2020 I would be saying it in an important named lecture, because that mental health struggles are still stigmatized and licensing still asks you about them in a way that is stigmatizing and, you know, not normalizing. Anyway, but for me, the skills that I developed during that episode of depression actually became applicable during Paul's illness and have protected me from burnout in certain ways along the way. And it's very simple things like making sure that I exercise. I started meditating around that time using guided meditation. I'm a big fan of the Headspace app, which is actually free for healthcare workers for a year right now during the COVID pandemic. Sleep, which is not under your control as a resident. And I think that's a very big deal and something that's very difficult for people. And then social connection. So I think it's been studied, including by Tate Shanafelt, who's one of the world's experts on burnout and got poached from Mayo to Stanford a few years ago to head Well MD at Stanford. He has studied the effect of professional connection, so social connection outside of work, but also professional connection in venues for us to connect with other clinicians who speak our language. And then, you know, I'll just mention that in Paul's book, so Paul writes sort of like a love story with one of his co-residents whose name, this was Greg Feldman, who was a Stanford general surgery resident and really close friends with Paul, and Paul admired him so much. And in Paul's book, he goes under the pseudonym Jeff, but he's one of the other people who dies in Paul's book, and he died by suicide as a fellow, which was an utter shock to everybody. And Paul was devastated. And the surgical residency at Stanford took on various changes after Greg died, thinking about burnout as a system issue. And I think, you know, it's exciting because there's actually a business case for reducing clinician burnout. There's a real connection with things like patient experience and quality and safety, as you might expect. But the reasons behind burnout include things like unrealistic workload and lack of flexibility and autonomy, and lack of meaningful tasks, and lack of peer connection and inefficiency. And so to study those, report on those, and work on system solutions is a huge deal. And I think one of the phrases that was most striking to me as I was learning about burnout as a system issue was, and I don't know the attribution, but someone I was listening to giving a talk said, if there's a canary in the coal mine, you can't just teach the canary to meditate. And I think that is such a big deal and really important because it takes away some of the burden from individuals. You know, I feel like if as a resident, you are experiencing burnout or you're experiencing anxiety or depression or whatever it might be, it's not that there's something wrong with you or something anomalous about you. I think it speaks to a much larger system problem. So anyway, I think about burnout a lot, and in particular as a place where, like end of life care, where the business case for solutions intersects with the moral case for creating solutions. And so thanks for asking about that, because I think it's a real form of leadership to be vocalizing that. It was not true as much when I was a resident 10 years ago. So thank you for being part of that change.
Thank you for sharing so beautifully sort of your own experiences. And I think this only helps anyone else going through similar experiences.
Yeah.
So thank you.
Lucy, I know we have some questions kind of in the audience, and I even saw a couple of kind of comments maybe from people who had known Rudene, so I'd love to save a few minutes to get there. But the last thing I kind of wanted to ask you about, just because you are in a large group of pediatricians and Mother's Day just passed, so I just wanted to ask a little bit about your daughter, and if there's any traits of Paul that you see in your daughter, and kind of how you hope to teach her about her father and this kind of legacy that he has, and then his amazing journey.
Oh, it's such a sweet question. Thank you. Yeah, so Katie is 5 now. She was 8 months old when Paul died, so she doesn't have a memory of Paul per se. She's very aware of him because I'm really close with Paul's family. Even right now, we're sheltered in place with Paul's older brother and his wife, who that's been very connecting and fun for me as a single mom. Yeah, so Katie is similar to Paul in many ways. First of all, the way she looks, because she looks like a little brown version of me. And so every time I look at her and her dark hair and her dark eyes and her amazing eyelashes, she has so many similar features to Paul that you can tell that she's someone else's daughter too. She is not a pleaser, which is like Paul, and it's difficult because it's like a whole toolbox of parenting tools that is totally unavailable to me in terms of she doesn't care if she pleases me. And then, so I have thought a lot about how to communicate to her about Paul and her own origin story, specifically for her sake and also for his. The family, I can't remember what it's called, Family Guidance and Bereavement Program or something at LPCH or Stanford Children's Health, was extremely helpful to us and actually involved in a number of things, including making handprints in the room when Paul was dying. Somebody arrived and started making handprints with us, and Paul was already sort of like asleep and dying, and they made a bear out of one of Paul's shirts. They lent me a lot of books about the wording to use with a young child about death, including seeing things like his body stopped working. Like there's research language about how to talk to a child. And then, so I gained a lot from those, social workers at Stanford. I ended up making a book for Katie about Paul, which sort of explains, this was when she was 3, it was on her 3rd birthday, but she still reads it all the time. And it includes a lot of pictures of Paul. And in a way, sort of treats Paul as a character in a book, right? Because she's like totally connected to characters in books, like, Pete the Cat and Madeline and whomever. And so it's a book just about Paul. Once upon a time, there was a little boy named Paul. Like, these are his brothers. He liked to read books. He loved dogs. He, was very funny. He tried hard. And then it talks about going to medical school and meeting me. And then it talks about like what an exciting time when Paul became a dad, and guess who the baby was? It was baby Katie. And then it goes on to say his body stopped working, and it has a lot of pictures of his grave site where we visit. It's close by. And then like many pictures of our family, sort of to put her in the context of this bigger family, even during loss. And so that has been helpful for her to see. And obviously when Breath Becomes Air is like waiting in the wings for her when she grows up. I think Paul would have been a great dad to a teenager with complicated questions where there are complicated answers or no answers. And so that feels like a loss to me in advance. And then I think, and also just like, there's the idea of, I don't want to canonize Paul either. He also was not a perfect person. He was just like a goofy, regular person. So I think it's even as a disservice to him, let alone her. I also try to think about like how to keep Paul as just a normal, complicated human being. through story. And then I'll just mention one other thing sort of about raising a child in this context, because, when you're a parent, at least I sort of used to have this idea of like, I am the creator of Katie's existence. So it's like, I am a reservoir, and then like, I can sort of like dole out like a world to her. And then obviously that's not the case even when she's 5, because she forms such interesting formulations about all of these big topics, including loss. And one instance and thing that she said that was so striking to me, other than the fact of just growing up into a reality that she just accepts implicitly, that actually has taught me a lot about acceptance. But there's something she said that was so powerful. She found this little golden bell that we had given as sort of like a party favor at our wedding. It's like this golden bell that actually came from India, and everybody got one. And she found one in our house because we had all these leftovers. And I was like, oh, you know what that is? That is a gift that we gave everybody who came to my wedding with Daddy. And she said, was I at the wedding? And I said, no. It's like so sweet, right? And I was like, no, you weren't even born yet. You weren't even born. And she said, oh, so was I in your tummy? And I said, no, you weren't even in my tummy yet. And she said, oh, well, yeah, okay. Well, that's because that's when I was dead. And it's like so interesting, because I think she totally gets that she wasn't there, but Paul was there. And then she was there and Paul was there. And then now she is here and Paul's not here. And so just this idea of like how a 5-year-old conceives of non-existence, and the fact that she would roll herself into that, in that equation. But meanwhile, it's sort of like a mind-blowing thing to say. I don't know. I just feel like that learning is going both ways, Anyway, it's been very special. And I sort of can't, I was less sure about having a child than Paul was during the time of his illness. And then, as with anyone who's a parent, maybe I can't, you don't do it because it's easy, but it's richly meaningful. So that's been, oh, here's my cat's tail. Anyway, just a wonderful thing. Thanks for asking.
Of course, we're always happy to hear about it. Thank you so much for touching on so many important and relevant topics for really all of us as pediatricians, as physicians, as family members of others. And it's really been wonderful to kind of have this discussion to help honor Rudene today in a really special way. So we'd love to take the last few minutes, and we can even go a few minutes after 9 if some of our audience and you can stick around to see what questions and comments the audience might have. And I know Jake has been moderating some of that. So Jake, do you want to share any of the comments or questions from our audience today for Lucy?
Thank you. We've gotten several great questions from the group today. And one of them is from Catherine Melsop, who says, I would love to hear Dr. Kalanithi talk more about something that you mentioned, operationalizing compassion. I'm not a physician, but help to steer a large team, and would love to hear tips, guidance, advice for guiding culture to embrace compassion in the workplace.
Oh, yeah, so this is not my area of expertise as far as like how to actually do this. And I imagine in the way that you're describing. But I think maybe I'll go back to what Rudene said, and it being the simple things. So as an example, I just saw, I guess one thing is like just the fact of you asking this question, right? And maybe the fact of mentioning to your team that it is one of the things that you value on your team and in your own leadership. I actually think verbalizing it goes a long way to set a tone. And then I think leading with an interest in people. So I saw a recent like set of do's and don'ts for Zoom meetings, which obviously we're all trying to figure out these days. And it talked about like the two things that stood out to me was, one of them said, do arrive on time. And that if you arrive to a Zoom meeting more than 5 minutes late, your team can lose about 50% of the productivity of the meeting, which I thought was really interesting, right? It's like a small implicit action that I don't know what it is. I don't know if it just it wastes time. I think it's more than that. My guess is that it has something to do with the message that you're giving people about valuing their time. And then the other thing on that list of things to do in a Zoom call was do lead with small talk. And that was kind of interesting too, right? And nobody likes small talk, but I actually think there's something about that, because telling people that you value them as actual people, to ask how they're doing. And then I think in the days of COVID, like there almost is no small talk, right? To ask how people are doing. If people answer that in any kind of real honest way, it gets into actually an intimate form of talk about meaning or fear or family connection or whatever. And then I think there is something about operationalizing compassion that does have to do with policy and leadership. So that could be everything from, like one example would be like having adequate sick time, or encompassing sick time to include family sick care, any amount of control that you have over policy that helps keep people healthy or emotionally and mentally well, I think is a very big deal. And so I would think about that as well. I'm just trying to think if I have anything else to add on that topic, because in a way I wish I could give you a more formed, comprehensive, evidence-based answer. And I'm sure I'll think of a million things later. So tweet me if you want, and then we'll talk more.
Thank you. We have a question from one of our audience members. As some of our family member may get ill or even critically ill, do you have advice on how to balance our role as a family member or a wife versus a physician?
Yeah. Yeah, I'm just trying to think, because it so much depends on the situation, right? And I think implicit in that is like a great responsibility that people who are physicians or clinicians feel to family members as the family local expert. I think it can be hard. So yeah, in the context of COVID and the fear about critical illness among family members, I feel like in a way, the expertise that is most important during a critical illness on the part of the family or patient is actually not medical at all. And it has to do with knowing a person, knowing yourself and your values, or knowing a person and their values, right? And I think the role that we can take as, and specifically what I mean by that is when you're doing end of life decision making, it is not simple, and it's making complex decisions in the face of unknowns and complexity. But I think if you know yourself, so let me give an example. When Paul was dying, he had a North Star. A lot of people who are sick, or a lot of people in general, right, have a North Star of what is most important to them. And for Paul, the thing that was most important to him when he was very sick was to maintain mental lucidity, to be awake, to be ideally spending time with Katie and our family, and writing as much as possible, because even until a few days before he died, he was sort of working furiously on the memoir, on the manuscript for When Breath Becomes Air. And so it's very clear to him, very clear to me, that he wanted to be mentally lucid. And it was what made the fact of his having brain metastases and leptomeningeal disease very devastating, because it started to bring into relief that we would possibly or likely be having to make decisions about trade-offs that where his ability to think and participate could become compromised. And ultimately, at the end of his life, when he was very sick, he was facing the decision about whether to go on a ventilator, whether to be intubated and have respiratory support from a ventilator, which necessarily includes sedation, and for the most part, often not being able to be awake or communicate. And as physicians, it was clear to us that perhaps most likely was that he would not actually be able to come off the ventilator and go home or achieve the goals that he had at that time. And so he decided not to be intubated, and he died that day, which I think was the right decision for him, and was very brave, because that kind of aggressive care sort of culturally and operationally right now includes that you have to opt out of it instead of opt into it, which is difficult and challenging. And I think even as two physicians trying to obtain the information that we needed and realize all the uncertainty, even as two physicians, is very difficult. But the thing that was actually most important was Paul knowing himself, which doesn't require medical expertise, right? And I think the role that we have as clinicians or physicians in families, to me, actually feels like the ability to get and explain complex information, literally in terms of just like translating literal vocabulary when physicians are using language that a patient might not otherwise understand, to be a medical interpreter of language, but also to explain probabilities and to help give a sense of perhaps what is, I think about this in prognostication, right? Like, what's a likely range of what will happen, or what is the best case scenario, the worst case scenario, and the most likely scenario. Like, if somebody can act as an interpreter of information and communicate the best, worst, and most likely scenario, in a way, I feel like your work as a physician stops there. I might be missing something, but this is my formulation currently. And then you can switch into being a person and helping your family members elicit and explain who your family member is as a person. And I think being attentive to that kind of decision-making is important. And I think ultimately there's so much, like, I think about like the trauma that can come out, the trauma and regret that can come out of decision-making around end-of-life care, and the way in which survivors can be traumatized, and the way that the way someone died can reflect into grief, right? It can carry you through an ocean of grief. It can cause additional trauma and regret. And I think it's important to remember that whatever happens, whether it's that someone's loved one had to die alone, or at least without a family member, right? You hope there would be, a gloved hand holding their hand, right? But it's like everyone's always doing their best. Everyone's always doing their best, trying to do their best on behalf of each other, especially family members. And so if communication gets bungled, or if someone died in a way that ultimately didn't quite make sense, I do think it's important to try to forgive yourself, maybe in the way that your family member probably could have forgiven you if they had been there. I just think so much about like the need for self-compassion during those decisions, because there is no perfection. It's all messy and complicated and sad.
Thank you. And what you said resonated very deeply. The thing that was most important was Paul knowing himself.
Mm-hmm.
And if it's okay, Dr. Kalanithi, I'd like to ask you a few more questions that we have from our group today. Yeah. This one comes from the topic of burnout, which you've discussed. And could you share more with us regarding the systemic changes that you advocate for with the mission of reducing physician burnout?
Yeah, sure. So, and let me just mention a paper that I really like. It's called, so I don't know the title. It was when Tate Shanafelt was at Mayo, sort of developing expertise as one of the world experts on clinician burnout. And again, this is the physician, he's a hematologist and physician who now actually is practicing at Stanford and leads the Well MD Center at Stanford, which is focused on physician burnout. And he wrote a paper with, I think, the CEO of Mayo, and it's called something like 7 Things That Executives Can Think About for Physician Burnout. And it's published, I think, in Academic Journal, but it's co-authored by Dr. Shanafelt and the CEO. And it basically talks about, number one, the importance of actually studying and reporting burnout the way we do other quality measures, because it's part of the quadruple aim in healthcare, thinking about quality and cost and safety and patient and clinician experience. So he talks about like, well, if you're actually going to make a difference here, you have to study it and report it. And then he talks about essentially the causes of burnout that have been studied, and then matching the solutions to those. And so the things that fall out when he studies burnout are sort of specifically things, these are the ones that I remember the most, are unrealistic workload, inefficiencies, loss of autonomy and flexibility, and loss of professional connection. And I think something about meaningful tasks, right? But I think that's tied up in efficiency as well. And then he talks about, okay, well, you have to measure it and report it, and you have to measure it locally, and then provide resources so that local settings, because, you know, like an ENT surgical center is different from outpatient pediatrics, which is different from inpatient palliative care, you know, whatever it might be. He talks about tailoring local solutions, but within this framework of saying, like, these are the things that tend to contribute. And so in your clinicians, what's most important? And then, you know, can you give them more flexibility over their scheduling? Can you make it so that there are support staff who can be doing these things instead of physicians doing them? Like, it's, he turns it into like not a mystery, which is wonderful, you know, because it feels monolithic and like a black box, and it's actually not. And so I think his research is so validating, but also so practically important. Oh, and for what it's worth, by the way, he also makes the very strong business case for reducing burnout. So in terms of quality and safety and then retention, you know, it costs like $500,000 to hire and train a physician and lose somebody. So he actually makes the case of attrition and turnover, and then the consequences of burnout to patients and the health system. He sort of argues that, you know, if you think you're going to lose money on doing this, you need to understand that you're going to lose money on not doing this. And that matters, right? If you walk into a leadership meeting or C-suite, you often have to demonstrate a business case. And it's very depressing / exciting that there is one, you know.
We still have a great number of people with us on Grand Rounds, and I wanted to remind everyone that the Grand Rounds is being recorded if you needed to step away and wanted to watch at a later time. And if it was okay, I was going to ask you a few more really good questions that have come in.
Great.
In thinking about the story that Marianne shared of Rudene's experience with insensitivity on rounds, what are your thoughts on doing bedside rounds rather than having most of rounds outside the door?
Yeah. So I love the idea of doing bedside rounds. It's more stressful, I think, as a clinician, right? Because you have, you know, and this is like when the team would enter the room and present the whole patient case in front of the patient, with the ability of the patient to interrupt or correct things and add, or certainly add things at a designated time. Same for family. And as a clinician, it makes it a little harder because we speak quickly in a language that patients don't understand necessarily, right? And so I think like that operationally, it's a little bit harder, particularly in that way. And so at least acknowledging that that's going to be the case, right? And say, you know, we're going to say things a certain way, and then we'll summarize, or we're going to, you know, whatever, however you're going to figure out the communication will work. But on the other side, as a caregiver, the day that Paul was dying, the team did bedside rounds and presented his case to us as a family. And I'm trying to even put my finger on like why it felt so important. I mean, one was just the pure fact of it. It said something really important about we were literally at the center of the discussion, physically and practically. And then it also gave us the ability to make decisions in real time that were going to make sense. So they sort of went through Paul's organ systems. You know, this is what's happening with FENGI, this is blah, 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 like organ system by organ system. And to give a sense of the clinical picture of the fact that he was critically ill. But then at the end, when they're making the assessment and forming the plan, there was sort of a group timeout moment of like, well, what is the big picture? And then what is the big picture in the context of Paul's goals? And ultimately, we were all there. We all made a very big decision. And actually it involved Paul like thinking things through more and like revisiting that discussion with space of a few hours. But I'm not even sure how that day would have happened otherwise. And anyway, I really like that idea. And I also think in a way, my instinct too, and probably someone has studied this, like we should look it up, is that my guess is that it's one of those things that on first blush, clinicians might actually think is going to make things less efficient. But in the end, my instinct is it might make things actually more efficient. The same way that in an office visit, when you set an agenda with a patient, if you keep saying, and what else, and what else, and what else, you feel like you're going to end up with this unmanageable list, but it actually gives you a list that you can then co-manage, even if it just means let's each pick one that we think is the most important and save the rest for a follow-up visit. It's like you end up with a connection and an agenda that everybody knows will make sense for everybody, and you get buy-in. Instead of having to negotiate an elephant in the room that hasn't been surfaced or whatever. So sorry, that was a long way of answering that question. After this grand rounds, I'm going to want to go look up the literature on bedside rounds, but to me, it has great face validity. Sorry, I feel like that's such a rambling answer.
That's very validating for our residents, I'm sure.
Is that what you guys do? Do you guys do it?
We do bedside roundings and have in our program many thought leaders around bedside rounds.
Really?
Yeah. So it's wonderful to hear your experiences and thoughts.
Yeah, good for you doing that. Good for you.
So many people have shared really beautiful reflections in the question and answers, and there was one in particular that we wanted to share with you and with everyone on about Rudene Di Carlo. This comes from Dr. AB, and she says, one of my favorite memories of Rudene is the time the team was trying to figure out how to get a kid with complex issues home for Christmas. During rounds, everyone decided it wasn't possible. Rudene, knowing how important it was to the family, wouldn't let anyone leave the workroom until they figured out a way to make it happen. And of course, they were able to figure out a way, and they got that kid home for Christmas. I've thought about that a lot during this time of COVID. We've had to apply that attitude toward caring for COVID-positive moms who are giving birth. What's easy for us isn't necessarily the right thing for the patient. But when we do the right thing for the patient, it's clearly worth all the effort.
Wow.
Thank you, Jake, for sharing so many great audience questions and that insightful story from Dr. AB, and kind of a reminder that there's still so many people that she touched by her kind of experiences that she had here as a resident. So that's most of the time that we have here for today. Lucy, I'd just like to take a moment to again say such a huge thank you, and for helping us bring up, so many inspiring topics, especially during this time that you mentioned can feel, lonely and distant for some, but it reminds us that we're all still a community together of providers, of physicians, of people who have gone through these experiences from lots of different perspectives, and for helping us come together to kind of talk about those things today. And I'd also like to say a thank you to Marianne, who joined us at the beginning of the talk, and again, Rudene's family and family friends for keeping this lectureship going year after year, and having us all pause to take a moment to remember her and reflect on these important topics. And of course, a thank you to Rudene herself for kind of inspiring all of us to be really purposeful and thinking of something that, like you mentioned, Lucy, isn't an afterthought, is a really crucial piece of how we treat our patients and how we treat each other. So thank you for everyone who's made this possible, and for our audience for all being here and joining us today.
Thank you so much.